Pleasure for me to speak on the effects of anti-cancer therapy on blood pressure and other cardiovascular parameters today. This is my conflict of interest declaration. Now, what's the problem? The problem is that cancer is on the rise, and particularly survival of cancer is on the rise. If we look at the data from the United States, which were just recently published in a very comprehensive manner, we see that in that country, each year, more than 1.5 million newly diagnosed cancer patients appear per year. But what's more important even is that there are 15.5 million cancer survivors. And the survival rate of cancer is gradually increasing. Progress in cancer therapy is not very fast, but more and more it is increasing. And we now have the situation that the 5-year survival rate in 2016 was almost 70%. So that means that this amount of patients will increase. And now on the negative side of that important increase in quality of health care is that 75% of cancer survivors have some form of chronic health problem, and cardiovascular disease is by far the most important one. We know a little bit about cardiovascular complications in cancer patients for some time already, but it is emerging as a major health problem in the past years, and I will go into the issue why this is the case. Cardiovascular complications were known for quite some time with the more classical anti-cancer drugs like doxorubicin, adriamycin, to affect the heart. That's been known for quite some time. But recently, we've seen with the newer anti-cancer agents that also stroke, particularly in patients with brain cancer that are being treated by either radiotherapy or drugs, is rapidly increasing. Pulmonary hypertension, vasospasms, thrombosis, stenosis, and very much so hypertension. The data on that, which I will show in a minute, are really alarming, I must say. The classical data, cardiac toxicity of doxorubicin, dose-dependent, is very well known, and I think most oncologists and cardiologists are aware of this. The incidence increasing quite much dependent on the dose of doxorubicin that is given, and reach levels up to 50% in those who are treated. And this is not only incidence of cardiotoxicity, but progressing to mortality as well. Now, we've seen a vast explosion of novel chemotherapeutics. Actually, this is the major area of pharmaceutical development. Pharmaceutical companies have almost stopped to invest in cardiovascular disease and have all gone to immunological and particularly oncological products. That's their major investment area right now. And we see some classical drugs like alkylating agents and antimetabolites, but particularly in the area of monoclonal antibodies and of tyrosine kinase inhibitors, we see an explosion of novel drugs, which are often not investigated from a point of view of their cardiovascular side effects. So they come on the market, and then cardiovascular problems occur. And particularly, I will focus in the next few slides on the class of the tyrosine kinase inhibitors, which have gained popularity through the pioneering work of Judah Folkman in Boston as angiogenesis inhibitors. And this whole series of NIPs, as you may want to call them, are on the market right now and are being investigated they are used in early stages of cancer, and particularly when there is angiogenesis as a progressing aspect of cancer. Now, there is an alarming amount of hypertension occurring with these agents. Within a relatively short period, up to 20 to 40% of patients develop hypertension with these agents, and sometimes very severe forms. And here you see in this rather complex set of data, all grade hypertension, the percentage, but if we look at the odd risk, the odd ratio, the risk that develops, it's up to a factor 3 to 5, and if we look at high-grade hypertension, it's even much more, 5 to 8 or even 22, with these individual agents that have been reported in the very good review paper by Herman in Circulation just last year. So this is alarming, the amount of hypertension that we see with these novel treatments. A few slides, although this is meant as a clinical talk, but just 2 slides on mechanisms behind this in order to understand why there is so much hypertension. Both these monoclonal antibodies and the tyrosine kinase inhibitors act on a system. Tyrosine kinase is central in that system of growth factors, VEGF, PDGF, FGF. These are all growth factors that are involved in the growth of blood vessels, and that's why they are a target to inhibit this angiogenesis and the spread of cancer throughout the body. Now, the mechanism by which an anti-angiogenic drug can cause hypertension was proposed by us actually already 25 years ago at the Madrid meeting of the European Society of Hypertension, and that is that reduced angiogenesis can cause hypertension. Hypertension is a microvascular disease to a great degree, and the disappearance of small blood vessels, rarefaction as it is called, is an important mechanism. This was delineated a long time ago already, so one could have seen this to come, and reduced angiogenesis causing hypertension, and in addition, some of these drugs also cause vasoconstriction because of an inhibition of the nitric oxide mechanism. So 2 mechanisms that contribute to the development of hypertension with these drugs. An alternative hypothesis was recently proposed by Abe and et al., but it would go too far for this teaching symposium to explain all the details of that, but you can see it on the web when this lecture is published there. And this goes through damage to the DNA, production of reactive oxygen species, and thereby affecting telomere dysfunction, and that would also contribute to the development of cardiovascular disease. But it's beyond the topic of my presentation to mention some details. The final 2 slides, 2 or 3 slides, I would like to spend on how to deal with this, because that's what we are facing in the clinic, of course. How can we avoid this new development of a very important hypertension problem and related cardiovascular disease? And we should be aware of this in patients that are treated for cancer. And I think the best approach is a risk-benefit assessment. On the one hand, persons that need to be treated for cancer need to have therapy, and we should be aware, and particularly the oncologist, when doing that treatment, should be aware that in some forms of cancer therapy there is a high hypertension risk. And I've mentioned already the VEGF inhibitors and some other drugs have a high hypertension risk. So already from the start of the therapy, one should be careful about that. On the other hand, part of the diagnostic workup in a cancer patient should actually also be the cardiovascular diagnosis and looking for risk factors for hypertension and events such as an uncontrolled blood pressure, organ damage, diabetes perhaps, risk factors. This should all be part of the diagnosis and start of the treatment. And this risk-benefit analysis then between these 2 factors should lead to a choice of therapy, and if the therapy is initiated, to also control the cardiovascular risk factors that are present and should be repeated during the treatment and should be followed up carefully in order to avoid these complications. And in my final slide, I would just like to summarize what this means for an oncology patient. Again, looking at the risk of hypertension in such a patient. Blood pressure should be assessed very regularly, should be measured in the first cycle every 2 to 3 weeks. Therapy should be initiated and intensified, and even if blood pressure rises to extreme values, one should think about a temporary hold or a dose reduction, because one does not want to reach the situation that a long-term treatment with an anti-cancer drug induces an immediate risk for cardiovascular death. That would be a very counterproductive approach. So in summary, oncology and cardiovascular disease have to do with each other, and particularly with the emergence of some powerful novel anti-cancer drugs. I think as hypertension and cardiovascular specialists, we should be very aware of this and diagnose and follow up our patients from this perspective. Thank you very much.